Classification and management of post-operative biliary stricture. Post-operative biliary strictures, POBS, are a significant complication following biliary or hepatobiliary surgeries, particularly after cholecystectomy, liver transplantation, or biliary reconstructions. They can lead to serious sequelae such as cholangitis, biliary cirrhosis, and liver failure. Classification and management depend on the stricture's etiology, location, severity, and time of onset. Classification of post-operative biliary stricture. POBS can be classified based on various criteria. 1. Etiology-based classification. Iatrogenic injuries, most commonly after laparoscopic cholecystectomy due to inadvertent ductal injury. Anastomotic strictures, seen after bile duct reconstructions, such as in liver transplantation or hepaticojejunostomy. Non-anastomotic strictures, NAS, often related to ischemia, infections, or immunologic causes in transplanted livers. 2. Location-based classification, Hiller strictures, affecting the confluence of the right and left hepatic ducts. Extrahepatic strictures, involving the common hepatic duct, CHD, or common bile duct, CBD. Intrahepatic strictures, rare but can occur post-liver transplantation or biliary tree trauma. 3. Severity-based classification. Complete obstruction, total blockage of bile flow. Partial stricture, narrowing of the bile duct with some bile flow maintained. 4. Timing of presentation. Early strictures occur within 6 weeks of surgery, often due to technical issues during surgery or anastomosis. Late strictures develop months or years after surgery, usually related to scarring, ischemia, or chronic inflammation. 5. Bismuth-Corlett classification, used specifically for Hiller strictures, categorized as follows. Type 1, stricture 2 centimeters below the confluence of hepatic ducts. Type 2, stricture involving the confluence but not extending into intrahepatic ducts. Type 3A, stricture extending into the right hepatic duct. Type 3B, stricture extending into the left hepatic duct. Type 4, involvement of both hepatic ducts. NASH management of postoperative biliary stricture. Management involves a multidisciplinary approach to address symptoms, complications, and underlying pathophysiology. 1. Initial assessment and diagnosis. Clinical symptoms: jaundice, cholangitis, pruritus, or recurrent biliary pain. Imaging studies: ultrasound and Doppler to assess bile ducts and liver. MRCP, magnetic resonance cholangiopancreatography, to delineate the stricture. CT scan for associated complications or anatomy. Endoscopic evaluation, ERCP, endoscopic retrograde cholangiopancreatography, to visualize and intervene. Liver function tests assessing bilirubin, ALP, and transaminases. 2. Non-surgical management, endoscopic therapy, balloon dilation of the stricture, placement of plastic or metallic stents for short or long-term palliation, endoscopic retrograde cholangioplasty for recurrent cases. Percutaneous transhepatic intervention, percutaneous transhepatic biliary drainage, PTBD, when endoscopic access is not possible. Percutaneous stent placement for challenging strictures. Pharmacologic treatment, antibiotics for cholangitis, ursodeoxycholic acid to improve bile flow. 3. Surgical management, indicated for refractory or complex strictures, including hepaticojejunostomy, Rugen-Y, reconstruction of bile duct continuity, particularly for extensive or high Hiller strictures. Biliary reanastomosis, in cases of anastomotic strictures post-liver transplantation. Liver resection or transplantation for severe irreparable injuries or associated biliary cirrhosis. 4. Management of complications, biliary sepsis, immediate drainage and antibiotics. Biliary cirrhosis, liver support therapies or transplantation. Biliary stones, lithotripsy or surgical removal. 5. Long-term follow-up, regular imaging and biochemical monitoring, surveillance for complications like secondary biliary cirrhosis or malignancy. Conclusion: post-operative biliary strictures require timely diagnosis and tailored management to prevent complications. Minimally invasive techniques are the first-line approach, but surgical interventions are crucial for refractory cases. Close follow-up is essential to ensure optimal outcomes.